Good morning, good morning, good morning. It is the last Fridays of the month. So you know what time it is. It is time for us to have another session of continuing medical education. I am so excited to have all of you here this morning as we have a wonderful education opportunity for you. Just our feedback. This morning, before we begin, we will begin as we usually do with a word of prayer. Father God in heaven, we come before you this morning, thanking you for another wonderful opportunity. We pray, oh God, that as we begin this education session, that you be with us, be receptive to learning. Pray that you would be with the speaker, that you would strengthen her to present to us today. We ask you to go before us, bless us, guide us. This I pray in Jesus' name. Amen. Okay, I'm still getting a lot of feedback. Just bear with me for a second as we sort that out. Okay, let's try that again. Oh, beautiful, beautiful, beautiful. Okay, so we have a very exciting presentation lined up for you this morning, and I will introduce to you that physician who will be providing us that education. But before we get into that, I came across something and I thought it was very beautiful, and I wanted to share with all of you this morning. It is a poem that was written by Miss Tossie Pugh, and it is entitled Purpose Over Pain. You rise before the sun ascends. Another day the care extends. White coats draped like armor strong to mend the weak, to right the wrong. Through weary nights and endless days, you serve in countless selfless ways. Yet tools are scarce, the weight is great, and systems strain beneath the fate. But purpose beats within your chest, a fire you will not suppress. Not for glory, not for gain, but lives restored through love and pain. The aching hands, the furrowed brow, the silent prayers you whisper now, the patient's hope, the family's plea, the battle fought that none can see. Yet, even when the road is steep, when promises feel hard to keep, you press ahead despite the strain, for purpose always outlives pain. So stand up tall, embrace your might. You are the healer's guiding light. No lack, no loss, no fight in vain will ever dim the lives you change. For though the weight may still remain, you carry purpose over pain. I thought that was such a beautiful interpretation of what we do every day as physicians. And as we approach the time where we recognize doctors in World Doctors Day, I would like to personally take the time to say a special thank you to all of you physicians who get up every day despite the pain, despite whatever you may be going through. You show up and you do the best for your physicians on a daily basis. I appreciate you, and I am most certain that your patients, who may not say it, they appreciate you as well. So without further ado, I would like to introduce you to our speaker for today.
Good morning, Dr. Wallace Bain, and good morning, everyone. Sorry for the late arrival.
That is fine. This morning we have presenting to us Dr. Shakera R. Carroll. Dr. Shakera Carroll is a family medicine specialist, having completed her residency training through the University of the West Indies School of Clinical Medicine and Research, Bahamas campus in 2013. She is a consultant in the Public Hospitals Authority and is currently stationed at the Elizabeth Estates Clinic. Her appreciation for multidisciplinary and patient care began during her time as a senior house officer in the internal medicine department at the Princess Margaret Hospital, particularly with her exposure at the weekly oncology tumor boards. Her interest in team-based medicine remains her interest in team-based care was and remains reinforced by her work as a primary care provider, with many of her patients having complex medical issues. As a patient-centered care is the core tenet of family medicine, she strives to incorporate collaboration into effective patient management. So please welcome Dr. Shakera R. Carroll presenting on All Hands on Deck, PHA.
Thank you
Dr.
for the
Carroll?
introduction. I have permission to share a screen.
Yes, you do. You can proceed.
Okay, 1 second for me. Okay, confirming that you can see my screen.
Yes, we can.
Okay, 1 second for me. There we go. All right, good morning, everyone. Thank you, Dr. Wallace Bain, for your introduction. And thank you to the CME department for the invitation to present. So I will preface by saying that I originally intended to give, a reboot of the previous presentation I had done a few years back, but I decided to go in a different direction this time around. So I hope you'll find the information useful. So I have no disclosures to make. And my objectives today are to define the concept and discuss the concept of the team approach to patient management, to outline the team concepts with respect to patient management, to provide justification for the team approach on patient outcomes, to identify the strengths and challenges with establishing and sustaining an appropriate approach to team care, and to discuss the recommendations for improving collaboration in patient management. So, together, everyone achieves more. Although we'll never really know who exactly came up with that term, the medical field slowly began to realize the importance of teamwork. In their landmark discussion paper in 2012, Mitchell et al. Commented on the significant scaling up of available medical research and clinical guidelines and protocols. They also noted that way back then, the emerging integration of technology into healthcare. Now we are in the era of advanced wearables, robotics, and AI. In addition, the average patient seeking healthcare was more complex, with multiple comorbidities jostling for prioritization. It was recognized that the diverse perspectives, knowledge, and experiences of other providers would potentially reduce harm to a patient, and that physicians cannot and should not operate in isolation. Because of this, the authors also acknowledged that despite having more hands on deck, patient care could still be compromised if teamwork was not of high quality. Thus, after extensive collaboration, they came up with a definition which, although it was created in the context of primary care, was robust enough to be modified for and applicable to multiple settings. So the definition of team-based healthcare is the provision of health services to individuals, families, and/or their communities by at least two healthcare providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated, high-quality care. So most studies and reference materials on team-based care primarily focus on physicians, advanced nurse practitioners, and to a certain extent, pharmacists, and the primary care setting. But I think that for team-based care to work, especially in our setting, there needs to be more of an appreciation for all of the personnel necessary to make a patient's journey as seamless as possible. These include nurses, physicians of all rankings and specialties, clinical providers in training, phlebotomists, lab techs, physio, and dietitians. But we also have to remember administrative leads, billing and collections, clerical risk management, patient care advocates, social service workers, housekeeping and kitchen staff, transport services, building and maintenance, and IT services. And I read through all of those because the average hospitalized patient will have either direct contact with or be impacted by the vast majority of these persons at least once during their admission. So it's important that ideally the team works in the context of the patient-centered management approach. So Mitchell et al. Also noted that the best of these team members possess the following qualities: honesty, where they strive towards effective and, more importantly, transparent communication, including discussion of mistakes with their team; discipline, where they execute their roles and responsibilities following established standards and protocols, despite discomfort or inconvenience; creativity, where they creatively view and address problems and see them as learning opportunities; humility, where they recognize that while training among team members is different, this does not make them wholly superior or inferior to anyone else, and they appreciate that everyone's opinions and insight have value, especially when it helps to avert failures in patient management. And finally, curiosity, where the team member is dedicated to reflection on the activities of themselves and others with the aim of improving themselves and, by extension, the team. So while it's recognized that each team would be unique to the institution, team members, scenario, and the patient and their families, there are a few core principles which guide sustainable team-based healthcare. Team members must establish shared goals which reflect desired patient management outcomes. These goals should be clearly articulated, understood, and supported by all team members. Communicating these goals effectively is key, and I'll give a pointer about that later. Each team member must also clearly understand their scopes of duty, responsibilities, and accountabilities, so as to not only avoid confusion, but to also protect themselves and the institution, and fairly and efficiently distribute tasks. Team members should also be able to trust each other to complete their goals as a cohesive unit. This trust is not automatic, but earned and takes time and effort to cultivate. So these principles are important as noted by Mehrota et al. Decreased coordination among healthcare providers led to adverse patient outcomes and an increased risk of lawsuits. Additionally, in addition to malpractice lawsuits, absent or ineffective teamwork can actually lead to other financial losses, from misuse and wastages of human capital and other resources and supplies, as well as increased recruitment expenses due to high staff turnovers. Fractured teams can also negatively affect the institution's ability to attract and retain quality staff. And therefore, the institution would not only have to address a reputation for substandard patient care, as mentioned previously, but also a reputation for being a less than ideal employer. So why would they have to be concerned about that? Because happy patients don't sue. In fact, they can potentially bring more funds into the institution. In their systematic appraisal of available research articles, Will et al. Found that team-based care was associated with higher patient satisfaction in the hospital setting. In their data analysis for global professional services, Collier and Mayer Basham found that hospitals with higher patient satisfaction increased their profit margins 70% over 5 years. And Richter and Mulstein found that positive patient experiences was associated with increased profits and an even stronger association between negative patient experiences and decreased profits. So, in addition to the obvious benefits for the institution, effective teamwork has added benefits for both the patient and the provider, with improved quality of care and outcomes, decreased team member workloads, and increased efficiency, resulting in decreased burnout and turnover of staff. So now that we know how teamwork helps, what are some of the barriers to its implementation and sustainability? So these barriers include lack of communication skills, differing professional cultures, traditional hierarchies, and assumed leadership parameters, role blurring, where there's confusion over boundaries and responsibilities, and these were found to be significant. So you didn't have to worry about trying to implement effective teamwork because it is achievable. However, it does take work. Sorry about that. Something froze here. However, it does take work. It takes collaboration in particular, but also takes participation, information, and having dignity and respect for all those members who are on that team. So according to the World Health Organization Framework for Action on Interprofessional Education and Collaborative Practice, interprofessional education occurs when two or more professionals learn about, from, and with each other to enable effective collaboration and improve health outcomes. The Interprofessional Education Collaborative, or IPEC, was formed in 2009 to foster collaborative learning among health profession students and built upon the work of the WHO. In 2011, the expert panel released a document on the core competencies required for IPE in practice, with the third version being released in 2023. These core competencies consist of values and ethics, where you work with the team members to maintain a climate of shared values, ethical conduct, and mutual respect. Roles and responsibilities, where there's use of knowledge of one's own role and the team members' expertise to address individual and population health outcomes. Communication, where persons strive to communicate in a responsive, responsible, respectful, and compassionate manner with team members. And teams and teamwork, where there's an application of values and principles of the science of teamwork to adapt one to one's own role in a variety of team settings. So the needs, goals, training structure, methods, and time frame would vary by institution, patient population, and illness or disease parameters. But at its core, interprofessional education would involve shared teaching and learning, assessment and implementation, and all of these are in the framework of institutional support. Once that training is complete, you'll have a practice-ready, collaborative workforce capable of facilitating improved health outcomes for patients. Now, this is just an excerpt from the Team Steps Pocket Guide, last revised in 2023, and designed to provide easily digestible tips to help you, your team members, and your patients to stay safe. So, in summary, team-based or collaborative patient management is an important component of achieving desired patient outcomes, promoting the well-being of team members, improving the functioning and efficiency of patient care, and protecting the institution from undue harm. Interprofessional training involves a shift in the mindsets of employees to see themselves as valuable in the patient care process and to learn to work together in a safe space of accountability and self-improvement. This training is key to effective team-based care and requires time, resources, and institutional investment. So it is my hope that with the investments in digital communications, with the PHA email exercise recently, the WhatsApp community, as well as the establishment of the PHA Academy, that interprofessional education and collaboration readiness will be incorporated into the training mechanisms for all levels of staff. Mommy. And so these are my references. And I thank you for your time and attention. So you may wonder why the presentation is a bit more abbreviated, but I did want to stimulate discussion on what I believe to be a very important topic, because each of the components of interprofessional training, whether it's within a team or if it is cross-sectorial, so for example, involving those non-clinical persons, the aspects of the IPC training itself, these are topics within topics within topics of themselves. And within my research, I found that there was mention of hospitals and other institutions balking at the idea of allowing physicians and other levels of staff to be excused from work with pay to receive this training. And they didn't actually value the importance of the training in the scope of improved patient outcomes. And it's only when the Affordable Care Act came into being in the United States that persons actually decided, or institutions actually decided, to take a vested interest in patient satisfaction, since this would actually affect their bottom line. So really and truly, the strive towards improving patient outcomes and patient satisfaction and patient care didn't come from a place of altruism or improved medical practice, but one of dollars and cents. And so really, I would hope that we're able to have a discussion about how that fits into our setting and how we can look forward to collaborating with each other to provide wholesome, effective, team-based patient care, and not just because it affects the bottom line, but because it affects our population health as a whole. So I'll turn it over to Dr. Wallace Bain and entertain questions and discussion. Thank you.
Can I have gummies, please? Can I have gummies?
Thank you, Dr. Carroll. Thank you so much for your presentation. You've definitely provided valuable information to stimulate our minds to really think about how to collaboratively approach patient care and management and the benefits that we can achieve if we are successful. I absolutely love the picture that is highlighted at the end because it truly embodies what we are aiming to do in collaborative care, showing that each of us holds a piece of the puzzle. And it's important for us to always think of the care of patients in that way, because no man is an island, and oftentimes we rely on other specialties, other areas to help put the entire picture together. So with that, I will open the floor to any questions or comments that you may have for Dr. Carroll. While you think about your question and your comment, I just want to remind everyone to please ensure that you complete the feedback for the presentation. The link is in the chat. And also, if you have signed on to this meeting in a name other than that which is registered at the Bahamas Medical Council, can you kindly change it to your registered name? Thank you. I think that was Dr. Grimes.
Yes, hi, thank you. Sorry, excellent talk, Dr. Carroll, and stimulated a lot of thought. I think I actually have two questions, one on both ends of the spectrum of this topic. One is that what steps do you suggest that we take as leaders to try and foster this type of relationship, because it is, I think it's going to be critical with us maximizing efficiency and outcomes and so on. And then on the other end, we've all encountered problems where I see many cogs in the wheel in your picture. What happens when you have a conscientious or unconscientious objector who doesn't want to participate and is holding up the process? So I'll just ask your input on those two things.
That latter question would be a little bit on my pay grade, but I'll try. With regard to the first part, you can't fix what you don't acknowledge. That's the first thing. So we have to be able to recognize as an institution, as a unit, that team-based care or collaborative care is important in the first place. You have to be able to understand where the pitfalls come with patient management when there's lack of communication, when there's wastage of resources, duplications, etc. And once you have that acknowledgement now, you can try to map out how you address it. So in order to do that, you're looking at one, identifying the persons who should comprise the team that takes care of that particular patient for that particular illness or diagnosis. Then you have to look at within these groups of persons, what is their skill set? Do they have the qualifications needed to perform those particular tasks that are necessary to achieve the patient outcome? Are those roles clearly defined in their job description? If not, what changes do you need to make to protocols and policies to facilitate that? Then beyond that, you're looking at what needs to be done in terms of training. Is that training going to consist of workshops, of dry runs or simulations? Is that going to consist of audits and feedback? So you have to be able to design a comprehensive module or course that's going to address the scenario and the patient outcomes that you want to achieve, and then be able to not only design it, but implement it, support its completion, enforce it, and be able to, again, like I said, audit and provide that feedback. To tie into the second question, one of the barriers that was highlighted by several of the studies I reviewed was the culture that exists among providers, and that's providers of all levels and skill sets. And so there has to be a entertainment of buy-in. And if you have persons who are resistant to the buy-in of having improved patient outcomes, then you really need to be able to sit down with that person and discuss what their understanding of it is, because sometimes it's just misunderstanding what the goals and aims and objectives are, especially if they're not communicated clearly. And if there's an understanding but still a resistance, to try to flesh out why that resistance exists and what can be done to mitigate it. It's then up to that individual if they want to be a part of the solution or part of the problem, and leadership would have to take whatever steps they deem necessary in the best interests of not only the institution, but the patient that they're serving, because that is paramount. Hope that answers your questions.
Yes. Thank you.
You're welcome.
Okay, thank you for that. Do we have any other questions or comments for Dr. Carroll?
While everyone is probably thinking and pondering, because I think the silence means that they're thinking about it, which is good, because there are lots of instances where you have adverse outcomes with patients' care, and there's finger pointing in terms of who did what or who didn't do what. So lack of care by omission or commission, but you should be able to operate in a safe space. And I think that's important to foster that level of not only accountability, but shared responsibility of support and guided constructive feedback to help persons who may be deficient in one area to elevate themselves. And if we don't have that, team-based care is not really going to work.
Definitely much food for thought indeed. So as a family physician, Dr. Carroll, oftentimes I know you would have to lean on other members of the medical team. What has been your experience in engaging a team-based approach when you are trying to provide care from an outpatient setting?
Okay, the setup question. Thank you, Dr. Wallace-Payne. Unfortunately, it's operating in a silo because as individual primary care providers, and I hear from my colleagues as well, we will reach out to our fellow specialists when it comes to handling a complex patient. So they have multiple comorbidities. I won't go into specific examples at this point in time, but they have multiple comorbidities. They need to be routed through several specialists to get feedback, to get optimization, to have procedures, etc. And sometimes you have persons who will immediately give feedback. They'll send a referral letter back with the patient. They'll give you a call or WhatsApp or an email, and you're able to have that line of communication open to make sure that your care overlaps appropriately, and there's no duplication of tests or inconveniencing with visits and so forth. And then you will have other instances where you don't get that feedback, you don't get anything in writing or verbally, and you're relying on the patient to recall what was mentioned to them in terms of their status, their plans or progress, and what is expected of them. I think that is unfortunate in the sense that it puts the patient in a vulnerable place, not being able to recall all of that information. And it also is inconvenient for us as primary care providers to have to navigate all of these things without all of that information available, especially without electronic health records in the public system in particular.
Yes, that is
stories too. So
yeah, that is indeed a challenge. So what would you then recommend to administration as to a way to navigate these challenges? Something that could be implemented in the immediate term?
Again, buy-in is key to it, but I do think a referral portal would be of great assistance, at least until the EMR is implemented and it's robust. You're able to just log in and view that information. But having a referral portal where you can exchange information, requests, available labs, get feedback on what is required prior to the patient presenting for another specialist to review. I think that would be a start, and having something that is able to be accessed and printed out and attached to patients' files where relevant. It's a starting point, it's a launching pad. And I'm sure that even with implementing that, there would be some challenges back and forth, some pitfalls here and there. But you have to start somewhere and be willing and able to build upon that.
Okay, thank you. I see Dr. Grimes, so
You're back.
I think he has a comment or a question.
Give me watch. Okay, yeah. So thanks. That's an excellent point. I just want to speak from the specialist side, I guess, a little bit. Just from our point of view with referrals, to say yes, and because it's also important for us to have some viewership of what their status of their chronic medical diseases are, and so on and so forth as well, because that has implications on our decision making. You understand? And so and as well as the fact that, sort of we get, like, just recently in clinic 2 days ago, I got a referral from someone with low back complaints who had sort of capably been evaluated by primary care and sent on for physio. But our process was such that the referral to me was processed and accepted quicker than the referral to physio. So they had now they said, even though they were sent for physiotherapy, it wasn't noted on the referral. And when they came, they acknowledged that they'd been sent, but just decided not to go, and hadn't been given an appointment yet because they wanted to see what I had to say. So that it was kind of one where they filled a slot where someone else could have been seen and evaluated with a better lens, and they could have waited till they had treatment, because that treatment might have avoided the need to see a specialist in the first place. So I just say that, like, yeah, I think we're dancing around and trying to create things because the EMR doesn't exist, and it would help us on both sides, not just on the primary care side, but it would help on the specialist side as well.
Yeah, it does complicate things when that happens, because even with that scenario you gave, just something as simple as the patient coming in and needing you and physio from a primary care provider, there's so many other cogs to that wheel, because now you have to consider appointment scheduling for both your clinic as well as the physiotherapist's facility. So are there overlaps? Are there backlogs that they need to accommodate? And as such, is that going to make the flow of visitations between both of you incongruent? And as a result, the patient is not getting a timely review that coincides with a certain stage in their physiotherapy management. So again, that brings in system-wide challenges that we have in the public healthcare setting, due to staffing shortages, resource shortages, whatever it is, that creates those bottlenecks that have patients waiting in one arena when they could have been getting managed in another.
Yeah, I mean, I worked in another national health system where there was long waiting times to see the specialist and long to access imaging and stuff like that there in Canada, especially for elective stuff. But what happens is, the difference is, because of the ease of getting access to information through electronic records or just general record keeping, it was easier to see where that person was in terms of their care. You understand? So it's not even so, even within resource challenges, that we have a better way of interfacing, then we would, I would know that they haven't started physio yet. So there's no need to meet accelerated appointment, because you've made a good assessment and you've made a good plan of treatment. And I only need to chime in after I get some information from the therapist in terms of their response.
Yeah, yeah, the EMR helps, because then again, like you said, you could just log in and see where patients are at. And we unfortunately don't have that. Plus, we're archipelagic. Plus, there's different records depending on which facility you're at. If you go to Elizabeth Estates, there's one record. If you go to Fleming Street or Flamingo, there's another. If you go to the eye clinic, there's a different record. And then if you're on the island, you're stuck until you get on a plane or a boat. So all of those things pose as challenges. And hopefully persons are brainstorming ways based on their experiences to navigate that and be able to share those ideas and have those ideas given fair consideration, because it's the people on the ground who really know what's going on. And it's unfortunate sometimes when persons who are not on the ground make certain assumptions or conclusions or policies that adversely affect those who have direct contact with the patients.
Yeah, very true, very true.
Okay, thank you for that very healthy discussion. And we have a comment in the chat. Thank you, Dr. Carroll, for this talk. I think the greatest barrier to our collaboration is poor communication between colleagues at every level. Poor referrals, paucity of documentation, and generally we don't speak to each other. Communication is a basic requirement for teamwork.
True and sobering, and unfortunately not new. I can think of so many examples where communication lapses created inconvenience for myself, for the patient, in some instances affect negatively and greatly impacted their outcomes. One particular patient I'm thinking about. And really and truly, again, like I mentioned earlier in the presentation, it's a change of mindset. You have to be able to recognize within yourself that something is not right with how this is occurring, and be able to say, okay, until the system catches up, what can I do as an individual provider within my scope of practice and training to be able to alleviate some of the burden and outcomes that we see with these patients.
Okay, thank you. We have another message in the chat from Dr. Lockhart. The bottom line is respect and appreciation for every member of the team.
Very much agreed.
And
from the top straight down to the porter. You know, you can't get the patients anywhere without them. And that's why I mentioned the non-clinical staff, because they facilitate the logistics behind a lot of the things that we need to get done. And it's not just about us diagnosing and treating, but all the other people who help to facilitate that diagnosis and facilitate that treatment.
Okay, I recognize Dr. Griffith-Bowe. You may go ahead.
Thank you. Good morning. So
Good
I wanted
morning.
to share that I was recently part of a training a training exercise for the for an electronic health portal for obstetric patients within the public health sector. I am almost certain that the family physicians should have been made aware of this. The medical records for maternity patients will be transitioning to an electronic interface. It is the exact same document that we currently use to document the care received by our antenatal patients, but it is in a digital format. And during the introduction for this training, one of the team members stated that the government is moving towards one patient, one record system. And it was interesting, some of the things that they discussed, because I was not aware that these things were already in place. And so I asked, why is it that the physician community has not been globally made aware of all the things that have been done towards moving towards a fully digital platform? And basically they said that, you know, they're working it out and preparing to launch. Now, I am aware that the EMR, the Ministry of Health-based EMR that was designed by a local team, was launched at the Adelaide and the Gambia public health clinics. I myself have not been exposed to this EMR as yet. I've only been exposed to the electronic record for the maternity patients. However, you may notice that devices are appearing in the clinics. There have been upgrades in terms of being able to provide internet throughout all of the clinics, between here as well as in the family of islands. And so I would encourage us, because it does appear that electronic health records within the public health sector is coming. I know that within the PHA, we are lagging behind somewhat. However, I believe that if one sector of health is able to implement a EHR, it would not be long before us at PMH would be able to be satisfied and get the similar digital records that we've been asking for. And they may very well use the same platform because it was developed by local experts who are on the ground, who knows our specific desires, who knows how we work, and who would also be available to fix any issues that might arise within the EMR. Thank you.
Thank you, Dr. Griffith-Bowe, for your commentary. It highlights again what I think that was Dr. Bassett and Dr. Lockhart were saying in terms of communication and respect, because really and truly, if something is being launched that is of importance to the physicians and needs to be accessed by physicians in order to provide optimal patient management, you shouldn't be amongst the last to know. In fact, you should be a part of the table from inception to lay the groundwork for how that system comes into being. So I guess glad you know now.
Okay, thank you.
Dr. Carroll, don't be surprised. This is how it is all the time, though, isn't it?
It is, and that's the thing. Like I was mentioning initially, I did a similar presentation to this about team-based care on a different topic and a different scope. But that was 7-8 years ago. I was reflecting to Dr. Wallace Bain the other day, and 7-8 years later, here we still are, not having moved forward significantly towards better communication, better collaboration, better inclusion when it comes to the policies and procedures that are needed to optimize patient management.
Well, we as physicians will continue to lobby because it is in the best interest of the patients that we serve. And that is the reason I think all of us came into healthcare to make a difference in the lives of the patient that we serve. So even though it continues to be an uphill struggle, we will continue to press on and hope to achieve the best for our patients.
I mean, to play devil's advocate to a certain degree. I mean, ideally, you're doing this for not only the love of your craft, because trust me, I have to love what I do, but also for the love of the patient and wanting them to be able to have a great outcome. But if that's not your motivation, then at least look to your wallet, because if the patient is not being serviced properly, they're having poor outcomes. You remember the legal team mentioned lawsuits. So if you want to be able to retain money, you want less lawsuits. Therefore, aim towards good patient care, highly effective team management. Beyond that, if you look at the profitability, especially in the US where they have Medicaid, Medicare, the facilities that invested in patient satisfaction actually had more recruitment and retention of patients and increased their profit margins. Like I mentioned, they were making more money because they invested in patient satisfaction. And they are now realizing that instead of trying to cut costs when they're in the red, simply making patients happier can, bolster their pockets, and by extension, bolster your pockets. Because it's harder to tell you, no, you can't get that raise if you are doing such a great job helping your organization to save money by not getting sued. Just throwing that in there.
Dr. Carroll, if I may.
Oh my gosh.
I think we have to, one of the things that has been recently instituted is patient representatives, and I don't know if those in this room have had a chance to peruse their general sentiment consensus, but I don't know if we realize, but we as physicians and the service provider in the public hospital have very high ratings. We just let the narrative occur where the outliers, which need to be dealt with and which cost a lot of money. But if you look at patient satisfaction as reported by patients to the patient rep, in clinics, in agape, in orthopedic clinics, surgical clinics, obs and gynae clinics, on the wards, is generally very good, in the 80-90+%. The problem is we spend too much time talking about the 5 to 10% and not dealing with it. as opposed to and admonishing us like we're doing a terrible job. You understand? So I just say that if we look at the fact support that generally, and I think Dr. Ferguson commented something in the chat there, is that like, yeah, there are instances of poor communication. Yes, there are people, yes, there's outliers of really, really bad results that need to be dealt with. But the majority of people are trying to do their job. And we have to push back on this narrative that, oh, it's a horrible place and this and so on and so forth, you know, because the numbers don't support it.
Yeah, and see, the thing is, you bring up an interesting point again. You're talking about the patient satisfaction, and anecdotally, we know that. Patients rave about us all the time at Elizabeth, you know.
But it's not anecdotal. The patient's rep have it. They have the data.
The patient's rep have it, but it's anecdotal to us because that information is not being disseminated where it needs to be. So that's what you're talking about now in terms of your PR vehicle.
Correct.
If you have these negative narratives out there, why aren't you promoting the positives? Yeah. Why aren't you having those patients give testimonials and saying how good their service was and how much they appreciate the efforts that the healthcare workers put into their management?
Correct.
We're not doing that.
Correct.
And therefore, those other narratives are going to take precedence.
And I think even to the point where we starting to believe it.
Well, we only could go by what we see in Harry.
No, but I know you to be an excellent doctor who takes care of patients. So I'm not going to let them beat you with that narrative.
Okay, thank you for that discussion. We have another message in the chat. While we do have instances of poor communication amongst our colleagues and gaps in patient care, there are definitely colleagues who are available by phone to discuss patients and give recommendations pending clinic dates. To echo Dr. Carroll, the buy-in by all is imperative for optimal patient care. Thank you for that, Dr. Ferguson. Okay, so I think we have had a very healthy discussion regarding our topic this morning. I would like to thank all of you for attending this morning's meeting. Again, I would like to remind each of you to complete the feedback for this presentation. Also remember, correct your name if you have not done so already. Your name should reflect the name that you are registered in at the Bahamas Medical Council. And coming up on March 30th is a day to represent you. So if you missed it at the beginning of our CME, I would like to reiterate again, I appreciate you. I appreciate all the work that you do, and I wish you all a very happy Doctor's Day. Show yourself some love and celebrate yourself. If no one else celebrates you, you remember to celebrate yourself on World Doctors Day. A wonderful weekend, and I will see you at our next CME session.
Thank you, Dr. Wallace-Payne. Thank you, Dr. Grimes. Thank you, everyone who commented. And hopefully this stimulates discussion and we have great things going forward. Thank you, everyone. Have a great day and a weekend.
Thank you.